Welcome, everyone. I'm Ninez Ponce, Director of the UCLA Center for Health Policy Research and Professor and Chair of Health Policy and Management at UCLA. And today we'll be exploring how to apply a data equity lens to data systems. This presentation is grounded in the work of the UCLA Center for Health Policy Research, which includes the California Health Interview Survey, the Native Hawaiian and Pacific Islander Data Policy Lab, and the Data Equity Center. Our work reflects our commitment to inclusive, representative, and community-centered data practices. UCLA honors the Gabrielino Tongva peoples as the traditional caretakers of Tovangar, Los Angeles Basin, and Southern Channel Islands, and pays respect to their ancestors, elders, and relations, past, present, and emerging. Our goals today are to define data equity, identify its key objectives, and introduce a framework for applying a data equity lens across the data lifecycle. That is, from collection to dissemination. I will draw on examples from the Center's California Health Interview Survey and the Native Hawaiian and Pacific Islander Data Policy Lab. We'll also discuss how disaggregated data improves quality and precision, especially for marginalized communities. By marginalized communities, I mean communities that have been historically under-resourced and underserved as populations that have been disadvantaged due to systemic inequities in areas such as employment, education, housing, food security, and healthcare access. These communities often remain invisible in data systems unless intentional efforts are made to engage them and disaggregate data to reflect their unique experiences and needs. Data are powerful tools. They inform health trends, policy, media narratives, and resource allocation. Importantly, data can expose systems of privilege and oppression, making equity-focused data practices essential. For example, in terms of health trends, the CHIS data revealed that Filipino adults in California have significantly higher rates of hypertension and diabetes than other Asian subgroups. This finding, made possible through disaggregated data, challenged the model minority myth and highlighted the need for targeted health interventions. For policy development, during the COVID-19 pandemic, the Native Hawaiian Pacific Islander Data Policy Lab used disaggregated data to show that Native Hawaiian and Pacific Islander communities had some of the highest infection and mortality rates in the United States. This data was used to advocate for more equitable vaccine distribution and culturally tailored public health messaging. On media narratives, findings from CHIS have been cited in major media outlets to challenge stereotypes and raise awareness about the unique health challenges faced by subgroups within the Latinx community, within the American Indian Alaska Native community, the Black or African American community, the Asian American, and the NHPI communities. Resource allocation. CHIS data on food insecurity among low-income Black, Latinx, and NHPI individuals with disabilities have been used by community organizations to secure funding for food assistance programs and housing support. And finally, exposing systems of oppression. Aggregated data often erases the experiences of marginalized groups, reinforcing systemic invisibility. By disaggregating data, CHIS exposes how structural racism, language barriers, and economic inequality intersect to produce health disparities. Data equity means increasing representation and access for historically excluded populations. It's about ensuring that these communities are visible in the data and have the tools to use it. Historically excluded population include racial and ethnic subgroups such as Native Hawaiian and Pacific Islanders, Black, Latinx, and disaggregated Asian American communities, example Filipino, Vietnamese, Hmong, as well as LGBTQ+ individuals, people with disabilities, immigrants, and those with limited English proficiency. These groups have often been rendered invisible in data systems due to aggregation, undersampling, or exclusion from survey design. Data equity ensures that these communities are not only counted, but also empowered. Data equity is not just about fairness in numbers, it's about shifting power. It means designing data systems that reflect the complexity of people's identities and giving communities the tools to tell their own stories and shape the policies that affect them. Equitable data practices ensure that these decisions do not reinforce existing disparities, but instead aim to eliminate them. The data lifecycle, collection, processing, analysis, and dissemination is not neutral. Each phase involves choices that can either perpetuate exclusion or promote inclusion. In collecting data, you can ask who is surveyed, in which languages, and CHIS intentionally oversamples underrepresented groups like Vietnamese and Korean communities and offers surveys in multiple languages. This ensures that people who are often missed in national surveys are included from the start. Processing. How are responses categorized? CHIS avoids collapsing racial and ethnic subgroups into broad categories like Asian or other race, which can erase meaningful differences. For example, Filipino adults, as I've said, have higher rates of hypertension than Chinese or Japanese adults, data that would be lost without disaggregation. Analysis. What questions are asked of the data? CHIS applies an intersectional lens, revealing how overlapping identities, such as being LGBTQ, low income, and Latinx, can compound mental health risks. This approach challenges assumptions and surfaces hidden disparities. Dissemination. Who gets access to the data? CHIS provides tools like Ask CHIS and community training workshops to ensure that community-based organizations can use the data to advocate for their needs. The NHPI Data Policy Lab goes further by co-developing dashboards with community leaders, ensuring that data are not just accessible, but actionable. Without intentional equity practices, data systems risk reinforcing the very inequities they aim to address. But when equity is embedded at every step, data becomes a tool for visibility, empowerment, and justice. When done right, data equity leads to better data quality, stronger community trust, and improved health outcomes. It also fosters sustainable partnerships rooted in mutual respect. Data equity is not just a moral imperative, it's a practical one. When communities are accurately represented in data, engaged in the process, and data access, then the quality of the data improves. People are more likely to participate in surveys, provide honest responses, because they trust institutions collecting the data. By involving communities at every stage of the data lifecycle, from survey design to dissemination, CHIS and the NHPI Data Policy Lab have fostered long-term relationships with trusted messengers, such as ethnic media outlets, faith-based organizations, and grassroots coalitions. In short, data equity transforms data from a tool of observation into a tool of agency. It ensures that communities are not just subjects of research, but co-creators of knowledge and solutions. The UCLA Data Equity Center aims to make data systems more inclusive and collaborative. We provide resources to help institutions better serve the communities they collect data from. The DEC was created to address the persistent gaps in how data systems represent and engage historically marginalized communities. Our mission is to transform data practices so they are not only technically sound, but also socially just. We do this by promoting inclusive data design, building community partnerships, and providing training and technical assistance to researchers, public agencies, and community-based organizations on how to apply a data equity lens. We develop tools and frameworks that help institutions assess and improve their data equity practices across the entire data lifecycle. Our work is grounded in the belief that data should not only describe communities, it should serve them. That means ensuring communities are visible in the data, have access to it, and can use it for advocacy, resource allocation, and policy change. In practical terms, this means helping institutions ask better questions, collect better data, and build better relationships with the ultimate goal of advancing equity and improving lives. The five principles of systemic awareness, equity-mindedness, inclusion, shared data agreements, and data sovereignty are adapted from the CDC Foundation and form the backbone of equitable data practices. I'll go over each principle with examples. To understand health outcomes historically, holistically, we must recognize that individual health is shaped not only by biology or behavior, but also by broader systemic, social, and economic determinants. These include systemic factors, for example, institutional policies, structural racism, and historical injustices that create unequal access to resource and opportunities. Social factors, community networks, cultural norms, education, and social support systems that influence health behaviors and access to care. Economic factors, income, employment, housing stability, and access to nutritious food, which directly affect physical and mental well being. These interconnected forces determine whether individuals and communities have the conditions and opportunities necessary to thrive, not just to survive. Equity-mindedness is not a one-time checklist. It is a continuous process of reflection, learning, and accountability. It requires us to use language that affirms dignity and avoids deficit framing. It requires us to disaggregate data to uncover disparities that are often hidden in aggregate statistics. It requires us to question assumptions about what is considered normal, effective, or relevant, especially when those assumptions are based on dominant cultural norms or majority populations. This mindset challenges us to interrogate the systems and structure that produce inequities rather than attributing disparities to individual or cultural shortcomings. In practice, we want to reframe decision making and data analysis to operationalize this equity mindedness. It's important to assess the impact of policies and practices, not just in general, but in terms of how they affect those with the least power or visibility. And it's important to reconsider analytic frameworks that treat one group, often white, affluent, or able bodied populations, as the default or ideal. Instead, adopt approaches that value plurality, lived experience, and community defined success. This shift helps ensure that data and decisions do not reinforce existing inequities, but instead contribute to transformative change. Proactive inclusion means intentionally engaging communities of interest, especially those historically excluded, in every phase of research and program development. This includes co-designing data tools with community input to ensure cultural relevance and sensitivity, modifying standard instruments, example in surveys and interviews, to reflect community values, languages, preferences, and lived experiences, ensuring transparency and reciprocity in how data is collected, interpreted, and shared. This approach shifts power dynamics, allowing communities to shape the narratives and outcomes that affect them. In practice, for community-centered data collection and use, default to flexible data collection methods that allow for multiple forms of identity and experience to be captured, such as open-ended questions, multi-select options, and aspirations. For example, in GIS, in asking about, what fruit juices do you drink, that we don't relegate to apple and orange juice, but also include favorite fruit juices from other cultures, particularly if you have a large immigrant population in your community large Latino population and community, that you might include mango and guava. So it's an example of cultural accommodation. Um, and you want to design for utility and impact. So ensuring that data can be used not only by institutions, but also by communities themselves for advocacy, planning, and accountability. So you want to make sure that the data products that you have are accessible not just to other academics, but accessible to smaller local health departments that may not have the statistical workforce, epidemiological workforce in-house, to community-based organizations that also are out there in the front lines doing service and advocacy, but may not have the investments for data analysis and data interpretation. Creating equitable data systems requires intentional collaboration between public agencies, researchers, and the communities most impacted by data-driven decisions. This means co-developing a shared data agenda that reflects priorities, questions, and concerns of both institutional, people who care about the issues that we're collecting on, and the community members. So planning for data completeness and quality, ensuring that data systems are inclusive, representative, and capable of capturing the full range of community experiences. Ensuring equitable access to data so that communities can use it for advocacy, planning, self-determination, and not just institutional reporting. Prioritizing data use that answers high-impact questions. As we say in survey world, there's only so much real estate that you have in the questions. You won't want to overburden a respondent. So really prioritize on what are the most important questions, especially those that address inequities, those that address uneven resource allocation and systemic barriers. Practice-centered community voices in data practices. So to make this happen, engage communities early and often in the data lifecycle, from agenda setting to distribution, dissemination, data sharing. Create feedback loops where community input is not only heard, but visibly integrated into design, decisions, and practices. The NHPI Data Policy Lab does this routinely by having town halls, by having meetings with community organizations, by presenting at community organizations at different stages of the development of data dashboards or policy platforms, to make sure that the community is aware of the production of the data set or the policy platform, but also that they can provide feedback along the way, not just at the very end. So build trust through transparency, sharing how data will be used, who will benefit, and how communities can access, interpret the results. And then honor community expertise by compensating participation. This is very important. Also by offering co-authorship on findings and recognizing lived experience as valid and valuable knowledge. To truly amplify community voices, we must go beyond inclusion and towards self-determination in data. Facilitating data sovereignty means paving the way for communities to govern the full data lifecycle, from what is collected to how it's stored, interpreted, and shared. Respecting community-defined priorities, values, and protocols in data practices, and shifting power from institutions to communities, recognizing that those closest to the issues are best positioned to define the questions and solutions. This approach ensures that data is not just about communities, but for and by them, supporting their goals, narratives, and agency. In practice, make data accessible and usable. Design for accessibility, use plain language, culturally relevant visuals, and multilingual formats to ensure data is understandable and usable. Invest in capacity building, provide training tools, technical support so communities can analyze and apply data for their own advocacy planning and storytelling. For example, in CHIS, we have a tool called Ask CHIS, which is a free web lookup tool, so that anyone with broadband access, of course, can log in and could could explore the data, look at crosstabs, look at specific counties, look at issues that they care about by race and ethnicity, by gender identity, by employment status, so that it is a way of democratizing the data to everyone. So ensure equitable access to infrastructure. This includes secure data storage, internet connectivity, platforms that allow communities to manage and share their data on their own terms. So all of this, of course, requires that there's absolutely a data security and privacy dimension of accessible data. And so that balance of freeing this data, but also protecting the data, because that's what we promised every respondent of a survey, every respondent says that we will make sure that their data is protected. So create feedback and accountability loops, which I talked about in the previous slide. And then this model of amplifying voices through data sovereignty transforms data from a tool of observation and again to a vehicle for justice, healing, and transformation. Some examples of data equity domains. Data equity spans multiple domains, from race and gender identity to structural racism and life course experiences. These domains help us understand and address disparities more effectively. Each domain represents a dimension of identity or context that can shape health outcomes and access to resources. When data systems fail to capture these domains or treat them as monolithic, they risk reinforcing invisibility and inequity and stereotypes. Here's how each domain contributes to a more equitable data landscape. So sociodemographics, CHIS, has collected detailed data on age, income, education, and employment. These indicators help social drivers of health, such as how low-income older adults experience barriers to preventive care. Detailed racial and ethnic groups, rather than using broad categories like Latino, Asian, Black, or African American, CHIS disaggregates data to reveal subgroup-specific disparities. Language. CHIS surveys are conducted in multiple languages, including Spanish, Chinese, Korean, and Vietnamese. This ensures inclusion of limited English proficient populations who often face barriers to care and are underrepresented in national data sets. Sexual orientation and gender identity. CHIS includes SOGI questions, allowing researchers to examine disparities among LGBTQ plus populations. For example, LGBTQ plus youth have higher rates of mental health challenges and lower access to affirming care. Disability. CHIS data show that people with disabilities, especially those who are also Black, Latinx, or NHPI, experience high rates of food insecurity and housing instability, revealing this intersection of ableism, racism, and poverty. Socioeconomic status, income, employment, housing status are critical to understanding health equity. CHIS data have been used to show how economic precarity affects access to care, particularly among immigrant and undocumented populations. Veteran status. Including veteran status allows for analysis of how military service intersects with race, gender, and disability to shape health outcomes and access to services. Structural and contextual factors. CHIS involves questions on discrimination, housing conditions, neighborhood safety. These data help illuminate how structural racism and environmental injustice affect health. In the life course experience, by capturing data across age groups over time, CHIS supports longitudinal insights into how early life conditions such as poverty, adverse childhood experiences affect long-term health. CHIS is not a panel survey of individuals, meaning that we don't follow individuals, the same ones over time, but we look at cross sections of individuals over time. So there is a longitudinal aspects, but it's repeating cross sections, not a panel survey. Panel surveys, though, are absolutely valuable in really understanding the life course experience. So data equity also means tracking how public policies, example, Medicaid expansion, contraction, language access laws, impact different communities. CHIS data have been used to evaluate the effects of such policies on coverage and care access and quality. Together, these domains provide a multidimensional view of health equity. They allow researchers, policymakers, communities to move beyond surface level what's going on for the average person, and it addresses the root causes of inequity.
We all belong to multiple social groups. Intersectionality helps us understand how overlapping identities shape experiences of privilege and oppression. Coined by legal scholar Kimberly Crenshaw, intersectionality is a framework that recognizes how systems of power, such as racism, sexism, ableism, and classism, interact to create unique experiences of disadvantage or advantage. In the context of data equity, this means acknowledging that people's health outcomes and access to resources are shaped by more than one identity at a time. Intersectionality challenges us to move beyond one dimensional analyses. It pushes data systems to reflect the complexity of real lives and helps policymakers design interventions that are more targeted, inclusive, and ultimately effective.
We'll now link these principles to the framework and explore how to apply them in real world settings. The data equity framework is designed to operationalize equity across the entire data lifecycle. It's not just a conceptual model, it's a guide for making concrete decisions that improve representation, inclusion, and impact. Let's look at how each principle translates into practice. Who is included in your data matters. We must consider visibility, trade-offs, and equity implications when identifying communities for research. For example, what communities are important to answer research questions? Relevant communities depend on the research topic and goals. Examples include indigenous communities, example Gabrielina Tongva in Los Angeles, for land use or cultural heritage studies, immigrant and refugee populations for research on integration, health disparities for education, youth and students for studies in education, mental health, or civic engagement, LGBTQ plus communities for research on healthcare access, discrimination, or policy impacts, low-income neighborhoods for studies on housing, environmental justice, or public health, rural communities for access to services, infrastructure, or agricultural practices, people with disabilities for accessibility, inclusion, and technology design research, racial and ethnic groups, example Black, Latinx, Asian American, Native Hawaiian, Pacific Islander, and American Indian Alaska Native communities for studies on structural racism, health equity, and policy impacts. These are a non-exhaustive list of examples on thinking about identifying communities of interests. In collecting data, context has to be considered. This principle is about how respondents understand and interpret identity questions during data collection, whether they are answering based solely on their personal identity or whether they see themselves as representing a broader group, example, their family, community, or cultural background. Why does this matter? Respondents may self-identify based on personal experience, ancestry, or community affiliation, and these interpretations can vary across geography. For example, the preference of the term Latino in California versus the term Hispanic in other states, and by generations, the term Latinx for younger generations versus Latino for older generations. Others may choose aggregated racial categories like African American or Asian, not just for themselves, but to reflect solidarity or shared experience with a broader group. JIS allows for self-identification across multiple race and ethnicity categories and includes detailed subgroup options, example Vietnamese, Korean, Mexican, Nigerian, Salvadoran. This flexibility respects how people interpret and express their identities, whether individually or collectively, and avoids forcing respondents into predefined categories that may not reflect their lived experience. What do we mean by equitable? Equitable data collection refers to the intentional design and implementation of data gathering methods that ensure fair representation of all relevant populations, especially those who are historically underrepresented and marginalized. This could be achieved by inclusive sampling, actively includes diverse racial, ethnic, linguistic, socioeconomic, and geographic groups, and by culturally responsive methods, questions, and outreach strategies that are adapted to be respectful and relevant to different communities. By inclusion means making sure no one is left out, no matter their language, background, income, or where they live. For example, in a health survey like CHIS, inclusion means asking questions in different languages so non-English speakers can take part, reaching out and oversampling people in rural areas, not just the big cities, making sure people with disabilities or without internet access can still be included. CHIS is largely a mailed survey with an internet address to take the survey online. But if a person doesn't have a computer or good internet access, then a phone interview is an option. And for those who don't live in a residence with an address, we use a prepaid phone sampling frame to expand our inclusive reach of populations. CHIS engages community stakeholders to inform coding schemes, especially for Indigenous and underrepresented groups, and also how to ask questions in terms of the labeling of race and ethnicity. And enforcement. So, enforcement means making sure the data is shared in a way that communities can actually use it to help themselves. Public tools like Ask CHIS, that free web query system I mentioned earlier, provide access to disaggregated data. Processing decisions are documented to support transparency and community use. Respecting respondent intent during aggregation and recoding steps in processing the data is important, and CHIS preserves self-reported race and ethnicity through detailed subgroup coding. For example, we actually now have the MENA population, the Middle East, North African population as a category, white and black subgroup categories per the revised OMB, Office of Management and Budget, SPD 15, Statistical Policy Directive 15 guidance that was updated in 2024. Also allows multiple race selections. Aggregation decisions are guided in part by the census directives, but also by analytic needs that aim to retain granularity where feasible. Equitable means consistency with respondent intent in processing decisions. So CHIS applies transparent recoding protocols documented in its various methodology reports. The multiracial responses are retained as distinct categories, avoiding forced single race classification unless justified by statistical constraints. Inclusion, the impact of processing on population representation is done through oversampling and stratified weighting to ensure visibility of small populations. We do suppress data for confidentiality, but we balance data suppression with the goal of maintaining subgroup representation visibility in public data sets and tabulations. For very confidential data or for data disclosure risk is high, a data access center is available for researchers to access the restricted confidential data. Collaboration. Community-informed recoding practices is important. CHIS consults with advisory boards and community stakeholders to refine race ethnicity categories and recoding logic. For example, the NHPI community groups have informed labeling of the preference of the use of Chamorro versus Guamanian as a write-in subgroup for the Pacific Islander race category. And also for researchers in re-aggregating data to intermediate categories, it's very important to consult with communities. The example that's top of mind for me right now is when the Hmong community contested the allocation or the categorization of the Hmong population under the intermediate aggregated category of East Asian, whereas the community um, through argued through the diaspora and through different cultural contexts were more aligned in the Southeast Asian category than the East Asian category. So consulting with communities has to be a necessary step when you think about processing data and tabulating the data. Enforcement just provides disaggregated data through ASCIIS and custom tabulations. Processing data decisions are documented to support transparency and enable community organizations to access data relevant to their constituencies. Are reinterpreting responses in ways that respect respondent intent and avoid stereotypes? In data analysis, context matters, especially when working with identity-based data. Analysts must consider how respondents understood and expressed their identities during data collection and avoid making assumptions that flatten or stereotype those identities in analyzing the data. So, key considerations for an equitable approach to analyzing data is respecting self-identification. Respondents may identify with specific racial, ethnic, or cultural subgroups. Analysts should avoid collapsing these into broad categories without justification, as this can erase meaningful differences. Avoid deficit framing. Communities that appear to have worse outcomes in the data, example, higher rates of chronic illness or lower access to care, should not be portrayed as inherently vulnerable or deficient. Instead, analysis should consider structural factors like racism, poverty, and access barriers. Recognizing data gaps. Some communities may be underrepresented due to language barriers, mistrust, lack of access, or too small a population to hit statistical reliability. So analysts should acknowledge these gaps and avoid drawing sweeping conclusions from incomplete data. Inclusion. JISC prioritizes disaggregated analysis to ensure that smaller or invisible populations are not overlooked. And analysts should work with community leaders to interpret findings in culturally appropriate ways and avoid deficit framing. Finally, for enforcement, analyses are reviewed to ensure that they do not perpetuate stereotypes or misrepresent communities. JISC data showed that LGBTQ plus Latinx youth experience high psychological distress. Rather than framing this as a personal issue, analysis focused on structural barriers like stigma and lack of access to affirming care. Data dissemination, or what we say often at the Center for Health Policy Research, data democratization, is about getting the data into the hands of the people, particularly those who are represented in this data, so that data just doesn't sit on the shelf, but it's actually collected for meaningful use. JISC provides public access to data through tools like ASCIIS Neighborhood Edition, which is a mapping tool, as well as ASCIIS is more of a data estimates cross-tabulation tool. And these tools allow users to explore data by race, income, geography, and more. The NHPI Data Policy Lab co-develops dashboards with community organizations to ensure accessibility and relevance. The current dashboards that we've been working on have been looking at social drivers of health, particularly those that are relevant to the Native Hawaiian Pacific Islander community. Enforcement. Dissemination strategies include training and technical assistance to ensure that communities can use the data effectively, and that there's also accountability in this dissemination. If we present something through different tools that cannot be accessed or is difficult to use, then it's through our communication and feedback in our training modules, our training videos that then help us improve the delivery of the training and the message. So during COVID-19 pandemic, the NHPI Lab's real-time dashboard helped NHPI communities advocate for equitable vaccine distribution and public health funding. Community-centered work identifies needs, strengths, and concerns. It builds trust and ensures that data serve the people they represent. Centering community means shifting the focus of data work from institutions to the people whose lives the data reflect. It's about recognizing that communities are not just sources of data, they are experts in their own experiences and should be co-creators in the data process. What does centering community look like? Well, in identifying needs, what we do in CHIS is we work with community advisory boards to ensure that survey questions reflect the real concern of diverse populations. For example, questions about housing insecurity, discrimination, and access to culturally competent care were added based on feedback from various community organizations, but also from researchers that devote a lot of their scholarly work on understanding the needs of populations that are made vulnerable by some of the structural inequities that they face. Recognizing strengths, community-centered data practices highlight resilience, cultural assets, and local knowledge. And addressing concerns, communities often express concerns about data misuse, misclassification, and lack of transparency. CHIS responds by offering multilingual surveys, protecting small cell sizes to prevent re-identification disclosure, and involving community leaders in data interpretation. So all of this matters, especially trust, because when communities see themselves reflected in the data, and are engaged in the process, then they are more likely to participate and share accurate information. They're also more likely to understand some of the decisions that we make in terms of disclosure risk and data suppression, so that it is a process that was well considered in protecting the identities of people, and not so much about overlooking certain communities by not presenting the data in data tables or in data reports. The relevance of the data is important. So it's shaped by community input and more likely to be used for meaningful advocacy, policy change, and program development. And then centering community ensures that data are not used to reinforce stereotypes, as we've talked about before, or justify inequitable policies, but it is to uplift voices and to drive equity. In practice, this means asking who is at the table when data decisions are made, whose stories are being told, who gets to use the data to make change. When communities are centered and data becomes a tool for justice, not just a tool for measurement. In sum, data equity isn't just about better methods, it's about better outcomes for communities. As we've seen, how we collect, process, and interpret the data shapes who is seen, who is heard, and who benefits. The work doesn't end with the data set, it begins with what we do with it. Thank you for your time and commitment to advancing data equity. Let's continue to do this important work together. And here's the contact information of our Data Equity Center Director, Dr. AJ Scheitler. Also, the URL for our website for additional resources. And thank you to my colleagues at the UCLA Center for Health Policy Research Data Equity Center, CHIS, and the NHPI Data Policy Lab. We are grateful to the Robert Wood Johnson Foundation for supporting the Data Equity Center. Thank you.